Harriet Washington, thank you so much for joining us. Before we get into your current work, I kind of want to take a step back, talk about Rochester. You grew up here in a way, you went to U of R, you ended up being a health and science editor at the Democratic and Chronicle. What was that experience like when they were reporting on such big issues in health and science in our area?
It was quite heady. I enjoyed the experience very much. And before I was health and science editor, I had a variety of positions, editorial positions there. And I just really enjoyed it. It was a great foundation. I hadn't gone to journalism school or taken journalism courses, so the on-the-job training was great. And like you said, there were a lot of very interesting issues to delve into. I remember being particularly enchanted by Parkinson's research that was taking place at the U of R, and having excited by the fact that I was able to cover that and be a pioneer there. So it was a great experience.
How did you move from journalism to academia?
It was actually a pretty smooth transition because I was at USA Today as a page one editor. Gannett had a loaned editor program, so editors would cycle through USA Today for half a year or so. And I was on page one, and my eye was caught by the fact that Harvard School of Public Health had 3 slots open for journalists. The catch was you had to actually be able to have the scientific criteria as well, but I did. So I applied and I got one of those there. And it was a wonderful year. I spent a whole year at the School of Public Health. They were kind enough to extend it for another year. And it was fantastic, but it was a very good transition because at the School of Public Health, I got the sort of background courses that were able to enhance my understanding of science to the point where it made me a much better editor. I wasn't writing at that point before I went to the School of Public Health. I had only been, not only, but I had been editing. But after that, I began writing vigorously. And so it was a great transition. It was, catalyzed by fellowship and Gannett's openness of letting me take it. So it was great.
How did your focus form on the disparities within the healthcare system when it comes to minority communities?
Well, my interest in medical ethics in general predated my work in newspapers. I had worked in a hospital for a very long time in a variety of positions, mostly pretty low level, secretary, technician in the cancer ward, but then I snagged my dream job running the poison center, and which was fascinating in many ways. But as it turns out, the most dramatic way for me was that when radiology gave us space in the hospital to expand, they left behind some old file folders. And I looked in these file folders, being the curious person I am, I won't say nosy, I read every case file. And I was really struck by what seemed to be divergent treatment and outcomes in the patients who are Black and white. Now, it was a small sample, so you can't tell from a handful of files that it's proof of disparity, but it certainly was a troubling pattern. And it was a troubling pattern I was seeing echoing elsewhere in the hospital. The staff had at that point in the early 80s, sharply divergent. The clerical staff, housekeeping staff, support staff were largely people of color, and the administrative staff and the intellectually powerful staff, department heads, were whites. And so no one was talking about healthcare disparities then, but there they were. They were slapping me right in the face. And without knowing what I would ultimately do with it, I began at that point to collect information. Everything from journal articles to reading a physician's memoirs in the medical library, collecting everything I could to bolster my understanding of whether or not there really seemed to be a racial divide in medicine. And certainly there was, as has now been amply documented.
And you documented a lot of that in one of your books in 2007, Medical Apartheid. What was the main message, the main finding that you tried to get across to folks?
My main goal was to correct the history of medicine. The history of American medicine elides, almost completely ignores the experience of African Americans, both as patients and subjects, and also as researchers who have helped shape American medicine. I had an interest in history of medicine, and I had already written papers and presented at conferences. And I was at a conference in Lübeck, Germany, where there was a collection of experts in the field. And I thought, wow, great chance to talk to all of them about what I'm finding and get their reaction. And there were only one woman there, rest were all men, they were all white, and they all said the same thing. Nothing happened to African Americans but Tuskegee. I already knew that wasn't true. I'd spent a lot of time in the bowels of the County Library, Harvard Medical School's medical library, and I'd collected information from it. So I knew that that wasn't true. And yet the premier experts in the world were telling me that nothing had happened. I wrote Medical Apartheid because I never wanted anyone to dismiss this history as being a myth. It needed to be documented. It should have been part of the canon of the history of medicine, and it wasn't. So I wanted to correct that. On the way to correcting it, I also found that it was very useful in terms of addressing ethical questions that have not been addressed very well in this country, and to help understand and offer suggestions about African Americans and how they can be more fully integrated into American healthcare. The healthcare system is deeply flawed, and it treats people of color differently. So documenting that and then suggesting ways of, ameliorating that is something that researching and writing that book allowed me to do.
When you talk about different treatment for people of color, what does that look like?
It looks like what we have today. Look at the coronavirus pandemic. We know that people of color are more likely to be infected and more likely to have disastrous results and die. And the reasons for that are really, clear when you look at other infectious diseases. What happened with HIV? The same thing. What happened with hepatitis C? The exact same thing. So people of color, consistently fare worse. They don't fare worse because they have different bodies. It's not biological dimorphism. They fare worse because we have a healthcare system whose policies and practices separate them from healthcare. If you look at coronavirus, for example, our policy is, to take one example, our policy is to prioritize elderly people. That makes sense at first glance. They're higher vulnerability, they're more likely to die, but so are African Americans. And when you prioritize people who are 80 years old and older, you end up working against people of color, because people of color in this country, African Americans, Hispanic Americans, Native Americans, are younger populations. The life expectancy is shorter, which means that we are a younger population, far less likely to reach that 85-year cutoff, and therefore far less likely to benefit from being prioritized. So even though prioritizing the elderly is something that we should do, absolutely, we need a more nuanced approach to it to make sure that we're not simultaneously penalizing young populations. It's only one example, and I could give you 100 examples, but you have other people to talk to, I know. The important thing is that we have actually now, with good data, excellent research, we now have a numeric record of this. We have proof that we didn't have 15 or 20 years ago.
Are you finding that the conversations are a bit more open to these ideas, partly because of the research that you've brought to the table?
Yes, I think partly because of my work, certainly. People are now aware of a lot of these things. But I think there's also something else happening. I think there's also a willingness in this country to engage with our very painful past, a past that is much easier to ignore or, sweep under the rug. And I find that people of all ethnic groups in general seem less willing to do that. Certainly in the medical arena, there's a willingness to take on head-on deficiencies of the system, failures of the system. And that change of heart, I think, is really, really important. It's just as important as the data we've managed to collect, because the data means nothing if you don't have people who are willing to use it in order to improve the healthcare of all Americans, not just some of them.
What type of solutions do you see that can help out the situation?
Oh, how much time do you have?
Go with what you got.
Okay, I have a lot. Okay, one of the problems with our healthcare system, one of the many problems, is that, again, we treat groups of people differently. We treat people of color differently than we treat whites. And we have documented this very well now. Look at pain control. We know now that just like the Victorian scientists who told the world that black people don't feel pain the way whites feel pain, We have consistently documented that in 2016, 2021, doctors still believe this. 2016 study from the University of Virginia documented that 50% of medical students surveyed think that Black people don't feel pain as whites do. 50% believe their skins were thick, they needed more radiation treatment, all kinds of beliefs that are simply not factual. And my concern is that you won't find a textbook that says that today. You won't find a textbook giving that information. I hope that no lecturers are telling students this. Students are learning this on the clinical floors. When they, after a few years of medical school, you go on the clinical floor, you begin to actually practice under the tutelage of a resident or a senior physician, and that's where students begin to see that African Americans in pain are routinely turned away as drug seeking. So we have things like that. We've documented them, but putting them into practice, taking the information and saying, okay, we want to start treating every patient in pain the same. How do we do that? That's going to take intention. And so far, we think about ways we can improve teaching and reward people. But teaching, I don't think is going to work well because it's not a matter of being taught something in a textbook. It's a matter of seeing practices. And also, rewards are important. People need to have the right behavior reinforced, but we also need to consider now punishment. We need to start treating people of color like whites is a quality issue, quality of care. It's a skill that you have to learn. It's like graduating from medical school and not knowing to treat every patient the same is like graduating from medical school and not having basic medical knowledge or skills. It's not acceptable, and we need to penalize people for it. So you shouldn't be able to graduate from medical school or finish your residency or indeed take home a full paycheck if you cannot meet these benchmarks. If you or your department or your institution is failing the patients that you see, then there needs to be some consequences for that, along with the education and support. I also think that a lot of policies that exist now operate against people of color. I'm not interested in discussion about whether it's intentional or not, whether it's explicit bias, implicit bias. What I find much more important is how to fix it. And one policy that comes right to mind, because it's so important, we're constantly bewailing our belief that African Americans won't engage in clinical research as they should. But that belief is actually erroneous. We can talk about that more if you like. That's actually not the case. But it is true that African Americans have been abused more often by the research system. So right now, our U.S. law dictates that you have to have a board that examines research proposals, decides which one actually get put into practice, which ones don't. And right now, you only have to have by law one person unaffiliated with the institution, and then the rest are scientists. You end up with like 15 scientists and one layperson. That one layperson can have absolutely no power and no clout in terms of swaying the opinions of the scientists there. They don't have any leverage at all. I propose since 2007, IRBs, these boards that approve or deny medical research, they should be half scientists and half lay people drawn from the pool where you're going to get your subjects. So if you want to do research at, let's say, Brandeis Medical School, then you ought to have like half the board made up of scientists and doctors from the school, and half the board made up of people who live in their catchment area, the area from which they draw research subjects. So if you do that, then lay people will have a real voice. And that's important because not only in terms of justice and ethics, but it's also important in terms of scientific acumen, because very often scientists are devising research protocols that are very good, look really good on paper, but if you don't understand certain cultural aspects of your community, it's not going to work well. Also, sometimes they're devising protocols and there's information they simply don't have. If you have lay people on the board, they can fill in some of the holes in the knowledge, not just cultural, but sometimes actual medical knowledge can be improved. The example that comes to mind is of one group that I'm not going to mention, but in that group they were talking about diabetes care. And so one scientist said, well, a lot of black people call diabetes sugar. So remember to use sugar in the informed consent form. And I thought, whoa, no, no. What he didn't know was that for African Americans in certain parts of the country, sugar and diabetes are actually two different diseases. People who have what they call sugar think they have a very mild form of diabetes that doesn't need treatment. He didn't know that. But if you did know that, you could write a better protocol when it's more appropriate. So anyway, I think that's very, very important. I also think it's very important for our laws to ban lobbyists from healthcare. Lobbyists pay lawmakers, essentially, to pass laws that will benefit their corporations, which means that we're voting in lawmakers to do our will, but they're not doing our will. They're doing the will of corporations. Pay them. Lobbyists should be banned. They have no place in healthcare. I think they are distorting a great deal of healthcare. A lot of laws are being passed that are, frankly, hostile to the health of all Americans, black and white. And so they just have no place there. So those are two big things I think need to be done to our healthcare system in order to improve it vastly.
Very good. And what's the focus of your latest work, which is coming out right about now?
It came out yesterday. Yes. It's called Carte Blanche, The Erosion of Medical Consent. I'm focusing on the fact that very few people know, in fact, many medical persons don't know. In 1996, two laws were passed very quietly. They became part of the Code of Federal Regulations, and they said that if you're an American with certain disorders or problems, research can be conducted on you without your knowledge, without your permission. It's a shocking concept. I mean, we think of the Nuremberg Code. Americans tend to assume that we live in a country where no one can do research on us unless we're given our permission, but that is no longer true. Very troublesome. We already have had tens of thousands of Americans enrolled in studies without their knowledge, without their permission. Some of the studies have turned out to test modalities that turned out to be, frankly, very harmful. Artificial blood was tested that way. And when the results tallied, we found that this artificial blood, called polyheme, was causing more heart attacks and more deaths than the standard of care. Right now in this country, there's a research team that is inducing hypothermia. If you live in Rochester, you know what hypothermia is, right? Yeah. Exposure to cold that lowers your core body temperature, which is extremely dangerous. In fact, doctors call that part of the triad of death. You know, you suffer hypothermia, your core temperature goes down, you can easily die. Very hard to save these people, and yet in Baltimore, they're intentionally inducing it in people. And they're doing it, they say, in order to see whether extreme cold might help them to survive. It doesn't seem logical to me. If you have read about hypothermia at all, it seems quite illogical. And I could not understand it. I still don't. But when I read the protocol description, I had a eureka moment because I discovered that the principal investigator has financial interests in it. If the study is successful, he will make money because he had patented some of the devices that are being tested. And I thought, oh, you know, perhaps the fact that he will profit finally is distorting, you know, his own risk-benefit calculations. So a troublesome trend in this country. It's being exacerbated by war and exacerbated by the pandemic, because urgency adds to the feeling among many experts and frankly all of us that we have scarce resources, we have dwindling manpower and time, and it's easier to cut corners. It's easier and quicker and cheaper to do research when you don't have to ask people's permission. That doesn't make it right. It's still wrong, but it's now the law in this country. So I'm deeply concerned that it's happening, and I'm even more deeply concerned that people seem not to know about it, which is why I wrote the book.
Well, thank you so much for sharing your thoughts on that with us, along with everything else. Harriet Washington, thank you for your time in general.
Oh, it's my pleasure. Thank you, Adam, for having me.